I'm here to present an interesting case for today. Our case is a 40-year-old female referred to us from gynecology, where she presented with a 2-month history of frank hematuria. The gynecologist did the routine ultrasound and saw what they thought was possibly a bladder mass. She has no smoking history and works in administration. Medical history: she's HIV positive, on treatment since 2016. She had previous pulmonary TB, completed treatment in 2008. Hypertension, on treatment, she's on amlodipine and hydrochlorothiazide for the last 3 or 4 years. Seems to be well controlled. She had a previous low-grade squamous intraepithelialized lesion on pap smear with a colposcopy results that was negative. That's why she initially went to the gynecologist for routine follow-up of this positive pap smear. That's when they picked up the hematuria and the possible bladder mass that they referred it to us. On exam, a BP was 125, over 85, pulse was 85, healthy female patient. On abdominal examination, she had a suprapubic mass palpable, non-tender. On PV, normal vagina and cervix, with a suprapubic mass palpable on bimanual examination. Ultrasound was done in the clinic, showed a large, well-defined bladder mass. CT scan was booked. Unfortunately, the date they gave us was significantly into the future, so we opted to take it to theater for a QRBT while we're waiting for the CT. At the transreferral section of the bladder, we find a well-defined bladder mass occupying at least 40% of the bladder volume, large base on the right lateral border bladder wall. Transreferral biopsy was attempted. It was abandoned due to severe bleeding, which led to poor vision and extremely high blood pressures, went up to 240 over 110. Unfortunately, that day we only had a very junior anesthetist assisting us in theater. When we went back to review the patient's anesthetic records, we found that the patient only received the induction dose of fentanyl and no other analgesia. In recovery, the BP is normalized very quickly. Was able to get a small sample for histology, not really the nice sample what I wanted to get, but we send it irregardless. Day 1 post-scope, the blood pressure was normalized in the ward, no blood pressure spikes. Pulse was normalizing, the urine cleared up, and the patient had no complaints. So he was discharged 2 days later to follow up at the clinic and for CT scan. Patient represented 4 weeks later with severely frank hematuria. She dropped her HP to 6.5. The decision was made to rescope her with the hope to control bleeding and to get some more tissue for histology. Unfortunately, at that stage, the first sample, we weren't able to trace any results, wasn't registering on the NHS system. Even with, at that stage, during this procedure, we had one of the senior anesthetists and one of the consultants in theater with us. The blood pressure spiked again to 240 with 150 with adequate analgesia and blood pressure control given by the anesthetic team. Yet again, day 1 post-scope, blood pressure and pulse normalized. So we suspected possible Pheochromocytoma or Paragondioma, and we decided to send a 24-hour urine analysis once the urine cleared up of the hematuria. The 24-hour urine sample came back. The normetanephrine was 56,000, with your normetanephrine creatinine ratio of 11,600, with the upper limit of normal being 250. So this patient was significantly excreting large amounts of normetanephrine. The first histology, we were actually able to trace it, went back to the lab, had a little bit look around, find the specimen eventually. Then they started to process it for us. They said that they sections demonstrated tumor exclusively, arranged in nests and trabeculations. The tumor cells were large with eosinophilic cytoplasm and indexing cell borders, mild pleomorphism and vascular chromatin. with prominent nuclei. On the immunohistochemical stains, the unfortunate only the CK7 and the CK20, which was both negative, and the GTTA, which was positive. And then they made a diagnosis of invasive urothelial carcinoma nested variant. And subsequently, the second histology also came out. Morphology was basically the same. They luckily did for us a bit of a wider range of immunohistochemical staining. We're showing chromogranin diffusely positive and synaptophosin also diffusely positive, and the KI67 positive at the border of 10%, suggesting quite an aggressive tumor. And then they made the diagnosis of infiltrating neuroendocrine neoplasma. On the CT scan, showed a bladder mass infiltrating into the abdominal wall, as you can see here on the picture, with positive lymph nodes in the right common iliac area, a cystic lesion on the liver. Here you can just see the bladder mass again. Here's the cystic lesion on the liver, which they were querying possibly a cystic metastases or just a cystic lesion. They weren't able to give us clarity on that. Then also ill-defined uterine mass. If you can see here, here's the uterine lesion, completely separate from the bladder mass, sitting quite anteriorly. Question was, is this now metastases? Is this local spread? Is it just a fibroid in the uterus of this patient? So assessment was a stage 4, T4B in3, neuroendocrine cancer of the bladder with a large small cell component. Currently, the patient was referred to Steve Biko Academic Hospital Medical Oncology Unit. She received 3 doses of chemotherapy. She's starting external beam radiotherapy in March with the hope to control her hematuria. We are waiting feedback regarding the histology. Asked the gentleman in the lab to just compare the 2 samples and see if they can make sense of what is going on, if it was just maybe that they didn't stain the right stains on the first sample, or if it is still 2 conflicting histologies, meaning that the patient has a mixed malignancy. She's also waiting a MEB scan. Hopefully that will clear up some of the gray fogginess regarding the liver lesion and the lesion in the uterus, to see if they are active or not. So to bring it to the discussion, unfortunately, this is a very, very rare tumor. Not a lot of literature available. They usually put it with the small cell cancers just to give it a bit more numbers. Otherwise, it ends up just having multiple small case studies. While the 3 theories of the etiology of having a neuroendocrine tumor or paragondioma in the bladder. First theory is that it is undifferentiated or stem cells within the urothelium, or second theory is that the neuroendocrine cells within normal metaplastic urothelium, and the last theory is that there's maybe a submucosal population of neuroendocrine cells. The big problem is with this, on normal specimens, we do not see neuroendocrine cells, so we're not sure exactly where this neuroendocrine cells come from to generate this malignancy. Presentation, most of them present like normal bladder cancer, urothelial cancer with microscopic hematuria, localized irritation and pain, urinary obstruction. The unfortunate part is most of them do present with distant metastases, and then some paraneoplastic syndromes, your hypercalcemia, your Cushing syndrome, and your sensory neuropathy. This is just the stage and the 5-year survival. Less than 5% presenting in stage 1, between 25 and 40% in stage 3, but only 63% survival for stage 2 cancer, which is very low. Stage 3, 24 to 30%, then survival drops to 15%. Stage 4, also 25 to 40%. then the survival drops to 10%. But as you can see, most of the cases presents either stage 3 or stage 4 cancer. I think this 44% is maybe a bit ambitious in the stage 2. It's normally reported as quite a bit lower than that. Why the histological difficult diagnosis? The nuclear detail gets destroyed, mostly by us. I don't think intentionally. We cause some crush artifacts or some necrosis, and then the high-grade neuroendocrine tumors can present as nest, and there's a significant overlap in the nucleus size and the amount of cytoplasm. So basically, from the histological point, it's impossible to differentiate on purely morphological analysis alone. So Thomas et al. Went and looked at 39 cases of high-grade neuroendocrine tumors or small cell carcinomas versus high-grade urothelial carcinomas to see what type of immunohistochemical staining possibly will be giving us some answers. The one that gave quite a bit of answers is the keratocyte punctuate cytoplasmic staining, which was positive in 86% of cases. Just want to also actually just mention the numbers. We're looking at 7 cases for high-grade neuroendocrine and 21 cases of urothelial carcinoma, and then 11 cases of mixed. So you get the keratocyte punctuate cytoplasmic staining, which is positive in the high-grade neuroendocrine and negative in urothelial carcinoma. And then the opposite is for your keratocyte membranous cytoplasmic staining, which is again positive for your high-grade urothelial carcinomas, but negative for your high-grade neuroendocrine. But I think the one that most of the labs use these days is the synaptophasin, which was 100% positive in all of the high-grade neuroendocrine or small cell carcinomas. And that's also the one, if you look back on the histology, that they did stain the specimen with. Cystoscopy, it's identical to transitional cell carcinoma. It's usually found on the lateral wall or fundus of the bladder. There is 1 or 2 cases documented of it involving the trigone or within a bladder diverticulum, but very, very seldom. To look a bit at the literature, Church et al. Did a clinical review in 2006. They did a PubMed search. They found that less than 1% of bladder malignancies are neuroendocrine or small cell carcinomas. They're usually present in advancing age 7th or the 8th decade. Very poor prognosis. Mortality is usually more than 50%, with a male to female ratio, which is quite high, 6:1. There's also a very strong relationship between smoking. I think that's maybe why the 6:1 ratio is still so high. As you know, bladder cancer now, the male-female ratio is getting closer together because more females are starting to they're smoking. But I think this is because it's so little information, the ratio is still a bit skewed. So they looked at the management for plain TURBT, very high relapse rates. Survival is usually between 3 and 6 months. You can combine it with radiotherapy. There's 1 or 2 case studies done that document here, but also median survival is 5 to 6.5 months. They say it's only actually an option for your sort of a palliative procedure for patients that doesn't have a very good prognosis. This is by no means a curative procedure. The only one that actually seems to do the patients a favor is a radical cystectomy, usually for early stages, stage 2, and possibly a highly selected stage 3 cases. In some series, your stage 2 cancers can have up to 75% disease-free survival. Unfortunately, relapse is still quite common in organ-confined disease, even confirmed on histology that it is an organ-confined disease. So you have to follow up these patients quite closely with routine CT scans to see if there's any localized recurrence. Looking at surgery of adjuvant and neoadjuvant chemotherapy, there is a significant improvement in survival, usually cisplatin-based chemotherapy. Surprisingly enough, a very high rate of relapse with the adjuvant compared to the neoadjuvant. with a 5-year survival of 78% in the neoadjuvant and only 36% in the adjuvant. Unfortunately, very difficult to mention anything about bias here, but probably suspecting that the patients with a better prognosis and a better clinical condition received some neoadjuvant, and your poor prognosis patients probably received the adjuvant chemotherapy. That's maybe why we're seeing such a big discrepancy between the two. Combined chemoradiotherapy study by Bex et al. They found 8 patients. They were taking any T stage, but unfortunately they could only find 8 patients, and they had a T3 or T4 lesion. They did a 2 RBT for the patient as complete as they could manage. Then they gave the patient platinum-based chemotherapy and then some radiotherapy. I think the radiotherapy, they gave them 62 gray in 2 gray units, and it was a cisplatin-based chemotherapy. All attained clinical response, but unfortunately, median survival was still only 15 months. But the big concern with this type of therapy was that the subsequent development of urothelial tumors was up to 40% in this population, in this study. Some studies say it can go up to 60% if you attempt to do combined chemoradiotherapy. And then they do mention quite a bit about palliative chemotherapy, yet again, cisplatin-based. There is 1 or 2 cases, yet again, of complete remission with survival of 3 years, but the median survival is 12 months. Unfortunately, with the limited data available, it's difficult to actually get proper statistical values for these cases. Most of them are small case series or case studies. Very interesting looking at the Mayo Clinic. I think this is where it started to hit home how rare this actually is. This is the last 20 years paragondiomas that they've seen in the Mayo Clinic. If you look here at the bottom, over 300 cases, basically 300 cases, only 2 were found in the bladder, which comes to equate to 0.7% in a 20-year period. Then looking at the small cell cancers, they look from 1974 to 2003. They pull their records to see what they have done in the 28-year period. They could only manage to scrape 44 cases together. 12 of the cases were stage 2, 13 were stage 3, and 19 were stage 4. Yet again, the majority of these cases are quite late stage, either stage 3 or stage 4. The stage 2 cancer, we look here that progression, recurrence, or metastases was up to 50%. 66% managed to survive. I think they mentioned a 5-year cutoff for the study. Radical cystectomies, the patients that did quite well, 6 of them. The neoadjuvant chemotherapy with radical cystectomy, 1 patient, unfortunately, but no evidence of disease at the end of the study period. And if you look at the stage 3, guys are doing the dismal year, 85% progression, recurrence, and metastases, only 15%. No evidence of disease at the end of the study. They did 8 radical cystectomies, 7 of them had recurrence or metastases. The adjuvant chemotherapy group did slightly better. Out of the 2 cases, 1 progressed, 1 did not. Preoperative radiotherapy did not do very well. And then if you look at the stage 4, there you go, chemotherapy. Out of 90 patients, 90% of them had progression or recurrence or metastases. Only managed 10%, 2 patients to have no evidence of disease at the end of the study. Chemotherapy all progressed. The only guys that did quite well was a radical cystectomy and adjuvant chemotherapy. Saying doing well is being generous. They did 10 cases, 8 of them progressed, and only 2 managed not to progress. Chemotherapy agents they mostly use cisplatin and etoposide as their first line, and then maybe adding some cyclophosphamide in a couple of cases. Second line, mostly carboplatin and etoposide of carboplatin and paclitaxel. And then for the third line, they use carboplatin and paclitaxel. So their suggestion was that all M0 patients, meaning no metastases, undergo radical cystectomy. All patients with metastases are fit for systemic chemotherapy. They don't advise any adjuvant chemotherapy for stage 2, but it's an option for stage 3 and 4. And they do mention a bit here that the guys in Florida did a study of quite good results, as we mentioned earlier, with the new adjuvant that can be used for stage 3 to 4 cancers. And there's my references. Thank you for listening.
Dr. Marais, thank you very much. Can you hear me okay?
You're very soft, Prof.
I'll try and talk a bit louder. Can you hear me now?
Yes, it's more clear now.
Okay. Dr. Marais, thank you very much for your contribution. I'm just looking around to see if there are any questions for this interesting case. I suppose the sort of overarching thing is that you have thought this patient to be in a palliative setting now. Is that correct?
Yeah, no, she's not doing quite well. Even with chemo and radiation, she's losing quite significant amount. And unfortunately, that our feeling is that mass is just too big for excision with the involvement into the abdominal wall already.
Yes, it certainly appeared that way on the CT, but I suppose one could repeat the CT and contemplate it, using it as a neoadjuvant and potentially proceeding to exenteration if we think the liver lesion is a met.
I don't really think it's a metastasis. I think it's more just the incidental finding, but unfortunately, we can't really say. That's why we're hoping with the NIBI scan that we can see if it is active lesion, then we know it is most definitely metastases. If it doesn't light up, I think we're still back to square one. Is it a lesion or not? But I think if we repeat the CT, we can reassess it and see what has happened after chemotherapy to that lesion.
Yes. Do you have access to MIBG to look for metastatic disease?
Yes, we are trying to get that. We just have a bit of a problem with the supply of the traces at the moment. She is discussed with them the moment they have the traces available, they will call the patient in for the scan.
These paragangiomas are interesting because they're often familial and associated with other things such as von Hippel-Lindau, etc. Has she got any family history, anything to suggest that possibility?
No family history, previously healthy, families all healthy, mom and dad is still alive. She's the first one in the family to have a malignancy.
One of the clinical things that often is important for urologists to have a handle on is the preparation of a patient with a pheochromocytoma for theatre. If you'd have taken the patient perhaps again to theatre, how would you have prepared this patient?
I would have definitely gotten we got the physicians involved to manage the blood pressure, but we would have started on an alpha blocker beforehand, and then possibly intra-op or just beforehand, maybe added a beta blocker to see if it is necessary. But yeah, and then also get the anesthetic team on board with this diagnosis so that they can also see what they can adjust on their side. But yeah, I would have gotten quite a few people involved in this, and possibly also get a high care bed or ICU bed available for this patient post-op.
Yeah, I think that's 100% right. The importance of starting the alpha blocker first is because if you start the hypertensive patient on the beta blocker, you get unopposed alpha, which is dangerous. And so then you would bring in beta blocker later if there's significant tachycardia. That's how I understand it. The important pre-op thing is to make sure that they're relatively well hydrated. Once you've done the excision of a pheo, they often crash their blood pressure, so you want to make sure they're full. And South African pioneer has pioneered the use of magnesium sulfate doing the management of the blood pressure intraoperatively, a bit like they would with pregnant patients. So that's a proudly South African addition to the literature. One of the important thing is clearly one abandoned the procedure because of intractable hematuria. Any other techniques you've got for managing intractable hematuria?
Ideally, we'd like put some hydrostatic pressure possibly on there to stem the bleeding. But in this situation, unfortunately, that blood pressure was just too high. So we working against pressures that we couldn't overcome.
Yes, so the anesthetic considerations take precedence. But your approach to a patient with intractable hematuria? The reason I ask about it is that, we've in fact lost one patient in the last couple of years who had intractable hematuria. So it's, again, a critical thing that a urologist needs to have a very clear stepwise approach of how to manage. I always joke with our colleagues that Enzo Ferrari, the maker of the fantastic car, said that his Ferraris were only as good as the brakes. In other words, it's no good having a fast car if it can't stop. And I always emphasize that principle when people are doing TRPs or TRBTs, that you've got to make sure you can stop the bleeding before you get off the table. But that's just one aspect of it. Anything you'd like to add how you might have stopped this bleeding here?
You can, things we weren't expecting this, but ideally preoperatively, you would have liked to check that this patient doesn't have any clotting abnormalities or high iron ore, that you can correct that before you get there and resuscitate the patient properly. And then intra-op, you can maybe try something like cyclopapron, FFPs, or some platelets if you can't manage it. And I think in a radical situation, if it comes to a point where you have to make a decision between life and bladder, you must maybe convert to a cystectomy.
Yeah, just a couple of cautions there. Certainly cystectomy is kind of the last possible option, but we're very anxious not to use cyclopapron. The reason being that it forms big clots inside the bladder, which can be even more of a problem to deal with sometimes than the bleeding itself. But clearly irrigation, the use of aluminium sulfate, the potential use of formalin, angioembolization, and a range of other things that need to be thought of. Hyperbaric oxygen in the setting of radiation cystitis, etc. So one needs quite a comprehensive list of how to manage these patients. I don't know if there are any questions for Dr. Marais. Dr. Marais, thank you for a wonderful talk, fascinating case, and let's hope the patient rallies and is amenable to cystectomy. I think that's what we've got to hope for your patient.
We all hope that.
Good.
Thank you, Prof.
Thank you very much. I see there's one chat. Let me see what comment that is. Yes, Lisa's just concurring the comment about cyclopapron. So we're moving on to our second interesting case from our colleagues from the University of KwaZulu-Natal.